The following podcast is part of a certified educational activity titled Experts vs. AI, Exploring New Paradigms in Comprehensive Care for Cardio-Renal-Metabolic Diseases. Access the entire activity and complete the post-test at peerview.com/RWH860. Downloadable slides and practice aids are also available.
Greetings and welcome to this program titled Experts vs. AI, Exploring New Paradigms in Comprehensive Cardio-Renal-Metabolic Care. We appreciate you joining us this evening on this presentation and the program, which I think has some interesting features, which we don't actually know how they will all play out, but we'll all do it together and see how it goes. So the way the program is constructed is that in the beginning of the program, we have some didactic slides and go over some material. And then we have a case, and the case will be built in a way that we will ask some question live to ChatGPT, and we'll get some answers from ChatGPT. And then we will go to a human large language model standing right next to me who knows everything, and then he will opine and compete with ChatGPT, and then I'll try to give some of my meager input. So I am Javed Butler. I'm a cardiologist in Dallas, Texas, and I'm really glad to be doing this session with my colleague, Dr. Vaduganathan from Brigham and Women's Hospital in Boston. So here are the goals that we want to proceed with today, is to talk about strategies to identify patients with cardio-renal metabolic comorbidities early in the course of their disease, to augment our abilities to apply current guidelines for the management of cardio-renal metabolic comorbidities, including in the post-MI setting, and to provide guidance on multidisciplinary care coordination for patients with cardio-renal metabolic or cardio-kidney-metabolic comorbidities. So without further ado, let's start with the program. So why talk about cardio-renal metabolic or cardio-kidney-metabolic diseases together? Well, the reason for that is that these comorbidities occur very commonly together. They are growing in proportion and prevalence in the population, but importantly, they have common underlying pathophysiologic mechanisms, and therefore, because of the common underlying pathophysiologic mechanisms, the bad news is that these diseases tend to cluster, and when they cluster, they worsen the prognosis. The good news, however, is that if you have effective therapies that are targeting those underlying pathophysiologies, you can expect, and as we will share some data with you tonight, that you can expect multiple organ system benefit. Also, these common pathophysiologic mechanisms, things like inflammation and oxidative stress, endothelial dysfunction, insulin resistance, adiposity, all of these things are associated with the development of cardio-kidney-metabolic diseases and progression of cardio-kidney-metabolic diseases. So in a way, we might see patients at one particular point in the journey of their disease that we found them with CKD or with heart failure or with diabetes, but you can be rest assured that the other disease process subclinically has started and that patient is at high risk for development of those diseases. But similar to my previous comment, the good news is that if you provide them with effective therapies, you reduce the chances of development of, and if they do have those comorbidities, progression of those disease and improve outcomes. Now here we see the NHANES survey looking at sort of this Venn diagram and the overlapping, how many people have type 2 diabetes, CKD, and cardiovascular disease, what are the overlaps, and then we also see that unfortunately none of those trends are getting better over the last decade, with a lot of people in the population have some stage of cardio-kidney-metabolic diseases. But as impressive as these numbers sound, 16.9 million type 2 diabetes and 9.5 million CVD, 18.5 CKD alone, and then that overlap, I can guarantee you that these are underestimations. And the reason why I say these are underestimations is because we don't do routine screening overall for the populations, and a lot of these things are sort of under the radar. And I think with more effective screening, we might realize that the true burden and the overlap may be even more dramatic. And as I mentioned, that once these comorbidities tend to cluster and aggregate in different patient population, they worsen the prognosis. So if you have, for instance, only heart failure, you can see the event rate in those populations. But now if you have these overlapping comorbidities, atherosclerotic cardiovascular disease, type 2, CKD, 1 versus 2 versus all three comorbidities, you can see that there are several-fold increase in the risk that these patients have for dying or getting recurrently hospitalized. So what are these stages that we are talking about? So this is the new concept of cardio-kidney-metabolic health that the American Heart Association Presidential Advisory announced very recently. And these are the stages of the cardio-kidney-metabolic disease. So stage 0 are patients who have no risk factors right now. So this is for primordial prevention, exercise, healthy diet, healthy lifestyle habits. Then stage 1 is where you have excess adiposity. That excess adiposity is putting patients at risk, but you do not have your early phase of this adiposity journey. You don't have any diseases per se. So you may have abdominal adiposity, you may have impaired glucose tolerance. Then you go to stage 2, you have metabolic risk factors, diabetes, hypertension, dyslipidemia. You go to stage 3, you start developing diseases or coronary disease risk equivalents. You have subclinical heart failure, atherosclerotic disease. And then stage 4 is when you have advanced cardiovascular diseases like peripheral arterial disease, stroke, heart failure, arrhythmias, and coronary artery disease.
So thank you, Javed, for that introduction. And unfortunately, despite the increased burden at the population level and the recognized intersection of these comorbidities, here we see that guideline-directed medical therapies targeting one or more of these pathologies is incomplete, slow in uptake, and variable at the population level. Here's just one example in patients after first hospitalization for heart failure. You see the uptake of various elements of guideline-directed medical therapy, and certainly combination therapies is markedly slow. And this is despite the wide recognition that combination therapy, especially when instituted earlier in the disease process, has the opportunity to truly bend the trajectory of illness. We can actually avert meaningful events, and we can extend survival in many cases to a substantial degree. We estimated previously that up to 6 years of additional life years can be gained with use of early comprehensive guideline-directed medical therapies. This risk treatment paradox, such that those at the intersections who face the greatest risks for near-term disease progression are the least treated in clinical practice, is really highlighted when we look at eGFR, or a measure of kidney function. Here you can see across the spectrum of GFR on the x-axis, those patients who have poorer kidney function face the highest risks of in-hospital mortality. Despite this, across every element of guideline-directed medical therapy, patients with poorer kidney function or lower eGFR were less likely to be treated with evidence-based therapies. And this is even above thresholds that we know there's effective and safe options that can be utilized, and even extends to therapies like beta blockers that don't interact with axes of kidney function. We also know that worsening kidney function or responses to therapy actually are one of the major reasons why we may halt, why we may interrupt, or why we may dose reduce evidence-based therapies in clinical practice. And this has been shown time and time again, and actually is sometimes more frequently reported even compared with elements like hypotension or other elements of intolerance.
So, this is interesting, right? What you just mentioned, that as the renal function worsens, the risks go up, the outcomes get worse, these patients need more therapy, and they're least likely to get therapy, right? So this is a real issue. Now, on the other hand, though, once we do talk about effective medical therapies, we have large randomized multi-center control trials, and we are talking about large trials that are several thousand patients that have been validated, so there's more than one trial, has gone through the review process with the regulatory agencies and the guideline committees, and there are many guideline committees without any controversy or without any disagreement that these therapies are foundational therapies that are class 1A recommendations for patients with various chronic kidney disease, chronic heart failure, or other diseases as well. So for instance, when we talk about SGLT2 inhibitors, for instance, in patients with heart failure, it really doesn't matter whether you're looking at American guidelines, European guidelines, Canadian, Australian, Indian, really doesn't matter. It's uniformly, everybody agrees on the evidence that in the absence of contraindication, that these medications should be given to the patients. Same thing for chronic kidney disease, but also these are not only agreements between the various different guidelines within a specialty, across a specialty, it's the same thing. So the primary care guidelines and the kidney guidelines and the heart failure guidelines and the prevention guidelines, all of those are giving basically the same recommendation for effective therapies for prevention in high-risk patients and for treatment in those who already have disease with cardio-renal metabolic diseases, to give these therapies like SGLT2 inhibitors and other therapies for which we have increasing evidence as well. So we mentioned about the SGLT2 inhibitors. There are clinical trial data that Dr. Vaduganathan is going to go over in a minute, showing benefit in patients with diabetes and in patients with CKD and in patients with heart failure. Heart failure data, regardless whether you have HFrEF, heart failure with mildly reduced, heart failure with preserved ejection fraction, in the hospital setting, worsening heart failure setting, and whether you're looking at outcomes in terms of cardiovascular death, heart failure hospitalization, recurrent heart failure hospitalization, stabilization of kidney function, decline, quality of life improvement, all of those things, reduction in albuminuria, all of those benefits are seen across the entire patient population. And now there is more and more evidence coming out with GLP-1 receptor agonist as well, although most of the data are in patients with diabetes kidney disease, for instance, with the FLOW trial, and data with also MRA is increasing as well, which doesn't really surprise us, again, because these drugs are affecting a fundamental pathophysiology which is involved in the development and progression of all these diseases. So with that said, let's talk about the CKM syndrome management recommendation by the American Heart Association. Now, there is no way to go through this detailed algorithm. This is available in your guide and in the material associated with this program, so please do download. Also, the actual presidential advisory can be freely downloaded through the AHA webpage and circulation webpage as well. So let me just take a few minutes just to highlight the top line message from these guidelines. So remember that stage 1 to 3 are people with either primordial prevention, no risk factors, or adiposity that is translating into development of cardiovascular risk factors, but no cardiovascular disease. So when you're in this earlier phase of the disease, the highlights are that 1, interdisciplinary care and address the social determinants of health. So we do realize that there are a lot of the diseases, development and progression are related to social determinants of health. So at least cognizant of that and trying to address that in the clinical setting is important. And also, while we all may be very good in our niche specialty, at the end of the day, communicating with the primary care physician and depending on the comorbidities that are affecting the patient, whether an endocrinologist or a cardiologist or a nephrologist needs to be involved. So interdisciplinary care and our other colleagues like dietitian or exercise physiologist, advanced practice nurses, all of those things become really important. Address obesity through multiple modalities. So again, we have at one extreme a lot of data over the past, over a decade now with bariatric surgery. In the earlier phase, we have a lot of data with exercise and diet and caloric control, and that science is burgeoning as well. And then obviously the biggest thing is with incretin-based therapy, GLP-1 receptor agonist, GLP-GIP, and a lot more of those drugs are being developed and will be coming out. So keeping up with that literature and management of obesity if you have the indication for pharmacologic management. But please do remember that pharmacologic management is in addition to lifestyle changes. This is not instead of lifestyle changes. So it's lifestyle changes and pharmacologic therapy as well for obesity management. Address and control CKM risk factors. So again, I would assume that most of the audience members here are in cardiology practice, regardless whether you are a physician, a nurse, a pharmacist, but you're in the cardiology practice. And one thing that the cardiology practice really needs to embrace at this point is evaluation of, for instance, albuminuria. That's the first sign of development of chronic kidney disease. In fact, not by proportion, but by absolute numbers, there are actually more people in the US with positive albuminuria whose GFR is more than 60, right? So again, getting our sort of suspicion at a low threshold and starting to diagnose these cardio-kidney-metabolic diseases, looking at NT-proBNP, looking at heart failure risk, those things become really important. Comorbidity-based approach for selecting cardioprotective anti-hyperglycemic therapy. Again, a little bit of a mouthful, but really important concept that we have evolved over the last decade. So it's not only about glycemic control. Glycemic control is important, but with those drugs that, along with glycemic control, also improve the patient's outcomes from cardiovascular and chronic kidney disease perspective as well. Things, again, like RAS inhibitor, SGLT2 inhibitor, non-steroidal MRAs, and GLP-1 receptor agonists, and prevent chronic kidney disease progression with these therapies as well. RAS inhibitor and SGLT2 inhibitors are now guideline recommended, and the role for GLP-1 receptor is increasing. And combination, aggressive, early intensive therapy in higher risk patients. Well, what about if you are stage 4? Again, the same basic principles remains the same. Along with the basic principle, start thinking about giving more focused pharmacotherapy for these patients as well, and more aggressive risk factor control with target like controlling blood pressure, controlling lipid based on those guidelines as well. Also remember that if their patients have more than 2 comorbidities present, then interdisciplinary care and getting multiple specialists involved becomes important as well, and that there should be some threshold that is identified within the practice settings of when to refer these patients as well.
So when I first saw the AHA Presidential Advisory on CKM, I thought to myself, is this just an epiphenomenon? Is it just that these conditions are so prevalent and have a heightened burden at the population level that is that explaining the entire intersection and the overlap? But I think one of the most compelling reasons why these disorders do belong together, these conditions should be considered together, should be managed together, is that the treatment of one condition appears to influence not just disease progression of that illness, but can actually influence clinical prognosis and events in the adjacent conditions. And I'm going to take you through really an avalanche of data. I understand you're postprandial here, and so I'll move through quickly. I'll give you some top-line summary statements to begin with, and then we'll quickly glaze over the data. So to start, foundational therapies for chronic kidney disease and diabetes. For instance, for chronic kidney disease, ACE inhibitors, non-steroidal MRAs, and SGLT2 inhibitors, each of these components reduce heart failure events independently. And so looking at that data, we really now have randomized data from thousands of patients with various compounds in each of these individual classes, and all have shown consistent and clinically meaningful reductions in heart failure events. So we can actually prevent heart failure even when we're using these therapies for other indications. We are using therapies for chronic kidney disease. In addition to slowing kidney disease progression, we could reduce heart failure events, and the same is true in the management of diabetes. Well, what about the onset of diabetes? Indeed, many components of heart failure care, like SGLT2 inhibitors, ARNI, the nonsteroidal MRAs, may in fact delay or prevent the onset of diabetes and improve glycemic control. The same has been shown in chronic kidney disease, that SGLT2 inhibitors can actually prevent diabetes. I thought these data were really, really interesting because some of these components, of course, have anti-hyperglycemic properties. I think many of you may agree, well, giving a glucose-lowering therapy to a patient with heart failure or CKD, of course, it's going to slow the progression of their glycemia over time to cross a threshold for diabetes. But ARNI, or sacubitril valsartan, and the nonsteroidal MRA finerenone don't have, at least clinically evident, immediate glucose-lowering properties, and their mechanism of action may have some off-target effects that influence metabolism. But in really fascinating recent data, it's been shown, in addition to SGLT2 inhibitors, these additional components, like finerenone, like the ARNI, sacubitril valsartan, can actually not only improve glycemic control in people with diabetes, but also in people without diabetes can actually slow or delay or prevent the onset of new onset diabetes. And the same is true for the final axis of kidney disease progression. When therapies are used for the management of heart failure and diabetes, there have been strong signals of reduction in important clinical events for kidney disease progression and also measures of improvement in measures of kidney function. Here you can see the data for the SGLT2 inhibitors and the ARNI, sacubitril valsartan, in patients with heart failure, and similarly with the SGLT2 inhibitors in the management of diabetes. So each of these axes not only cross-sectionally overlap, but they longitudinally influence the development of each other. One condition increases the risk of the development of the other, and importantly, those risk pathways are modifiable by a very similar set of therapies. So in my view, this is some of the most compelling evidence that these conditions truly do behave and belong together. And finally is related to ASCVD, or major adverse cardiovascular events, including atherosclerotic events such as myocardial infarction and stroke. And in fact, the same is true. Foundational therapies used or indicated for chronic kidney disease and diabetes, again, have been shown to reduce those ASCVD events. And this is really summarized by important reductions in major adverse cardiovascular events with the SGLT2 inhibitors and the GLP-1 receptor agonist. So the other compelling rationale, not only that they influence the trajectories of each adjacent condition, but using these therapies in combination can actually improve the tolerability of each of these agents. For instance, MRAs, which are largely underutilized, especially in the United States because of concerns around hyperkalemia, their use may actually be facilitated with concomitant use of an SGLT2 inhibitor or an ARNI, sacubitril valsartan. The same is true and has been observed in chronic kidney disease, that SGLT2 inhibitors can actually facilitate ongoing use of multiple components of disease-modifying therapies in chronic kidney disease, such as RAS inhibitors, MRAs, and endothelin receptor antagonists.
Okay, so where do we then end with all of these data? So the good news is that with the overlapping pathophysiology and with the drug mechanism of action with some pleiotropic effect, so yes, you can have glucose lowering with SGLT2 inhibitors, but then you have all of these data on improvement in endothelial function and reduction in inflammation and oxidative stress and reduction in adiposity, similar data coming out with GLP-1 receptor agonists, with all of those pleiotropic data that is coming out with these medications, followed by clinical trial data for benefits across multiple different disease states. this is great. We can actually make our patients live longer and live better with less comorbidity burden, improve quality of life. And the fact that all of these data, there's really no controversy per se. I mean, the issue is implementation, but there's no controversy. Guidelines, international guidelines are all integrated. And as I mentioned, whether the guidelines are across different regions and countries or across different specialties, they are all sort of harmonized. And then the question is that in this sort of burgeoning age of artificial intelligence and electronic health record and natural language processing and being able to send messages to the patients and messages to the clinicians and all that kind of stuff, can we potentially use all of these technological advances to further enhance the care so that we can give timely, intensive care to our patients and perhaps even match that in terms of their risk. Now, the challenges are, however, that the number of patients with the number of comorbidities is increasing, so there is a significant burden on the healthcare system. So those are the challenges. There are competing priorities, the number of patients, the number of things we need to do, documentation, insurance-related issues, quality related issues, all of those things, and the limited clinical time. And at some point, the guidelines are maybe too many and too big. So even single disease guidelines are just really thick documents, multiple angles that are covered. And really there is a tension, right? I mean, we can criticize the guidelines, but then what would they do, right? I mean, this is so much evidence in so many sort of nuanced ways that they are trying to summarize, and the summary happens to be quite big. And then you're talking about sort of multiple things. So that's where this issue of AI sort of comes in and see whether it can help. So we're just going to sort of play with it a little bit for the next 30 minutes or so. So there is a case that we will read the case, and in the back they will feed the case to ChatGPT. We'll get the answer from ChatGPT to see what the ChatGPT says, and then we'll see whether we agree or disagree. And I think it'll be fun if ChatGPT and my colleague and I all three disagree with each other, and then you can just pretty much do whatever you want to do. How would you evaluate a man age 57 years who's overweight, has dyslipidemia, hypertension, who visits his cardiologist due to fatigue, achy muscles, poor exercise tolerance? Okay, how can I help you today? So let's put in the case and see what ChatGPT would do. Assess for possible cardiovascular issues, ischemia, heart failure, through physical exam and history. Review medication history as muscle symptoms could indicate statin-related myopathy. Consider further tests, ECG to assess heart abnormalities, echo for cardiac function, stress tests to evaluate exercise capacity, blood tests, for example, creatinine kinase for muscle damage, thyroid function, metabolic panel can help rule out the causes like hypothyroidism and electrolyte abnormality, adjust medication and lifestyle based on findings. So the ChatGPT agrees with the audience, do everything. So this is not going to be a cost-effective care, but again, we give it a little bit of a nondescript case. So the bottom line is assess for statin-related myopathy, consider ECG, echo, and stress tests, use blood tests to assess CK and thyroid function, etc. So Dr. Vaduganathan, what do you think? This patient, stage 2 CKM higher, do you differ from the chatbot?
You know, it's interesting this patient is presenting to cardiovascular care, although I suppose that many of us do provide a degree of primary care. And this is sort of that initial line of defense, and I think a broad workup might be reasonable if at least the onset is acute and perhaps the severity is greater. If they're milder symptoms, I'm not sure if I would do the gamut of testing. I would think about other common things being common, like infectious symptoms and infectious illnesses in relatives.
Well, I have to say, I mean, I am hard-pressed to consider a stress test in this guy. I don't know why you would need a stress test in this guy at this point. At least to me, based on the information we have just yet, echo seems a little bit of a stretch as well. And I think just ECG, good physical exam, good history, and some labs, and just see what happens. But by show of hands, would anybody want to do a stress test in this person at this point? Especially, okay, so one person. Okay, so Dr. Vaduganathan, ChatGPT, and one audience member. Okay, so let's build up the case. Now, physical examination, heart rate of 70, blood pressure 140/80, normal skin color and electrolytes, pedal edema with normal pulse, no liver spleen enlargement, UACR of 45, EGFR of 60, total cholesterol 220, any further test indicated. So we're getting some cues of EGFR, cues of UACR. Okay.
Yeah, I'm truly interested in what they're going to do with normal skin color and electrolytes.
Further test may be warranted to clarify the underlying cause of patient's symptoms and to guide management. Given his GFR of 60 and albumin, urea, I guess is what they're saying, 45, additional tests include NT-proBNP or BNP to assess the heart failure possibility and possibly an echocardiogram to evaluate cardiac structure and function, reassess lipid profile and consider fasting glucose or hemoglobin A1C to rule out diabetes. Regular monitoring of kidney function, albumin, urea, and electrolyte is recommended. Depending on findings, treatment adjusts, RAS inhibitor, SGLT2 inhibitor may be necessary. So, Dr. Vaduganathan, are you pretty much convinced that this person, GFR of 60, UACR of 45, that this person has CKD? Are you unwilling to give him the diagnosis and you want to repeat the labs?
Yeah, so by the books, by the guidelines, we do require serial assessment because you do want to exclude the possibility of acute perturbations that may influence kidney function. However, this person has now 2 axes of kidney function that are abnormal, and the UACR tends to be quite stable, especially in the outpatient setting when measured, and now has now crossed the border of A2 albuminuria. And so this person does have chronic kidney disease, and in fact now does qualify for many evidence-based therapies.
So the issues, if we were to start lining up in this case so far, blood pressure, UACR, chronic kidney disease, total cholesterol. Do you want to do an echo on him or just do NT-proBNP and see what it is?
Yeah, I think initial screening with blood-based markers makes sense as a sort of a triage mechanism. We do need to recognize natriuretic peptides can be normal in some of these individuals, especially who are overweight or obese, because of adiposity-related neprilysin and sort of constitutive lower levels of natriuretic peptides in those populations. But nonetheless, I think it is reasonable to start with natriuretic peptides if abnormal and do serial testing with an echocardiogram.
I mean, one thing I would really emphasize to our colleagues here, I mean, if you look at the epidemiology of CKD, there are like these many patients with stage 3 CKD and these many patients with stage 4 CKD. So the question is, what happens from here to here? And the problem is that all of these patients unfortunately died, and they died of cardiovascular disease. So early forms of CKD is really a cardiovascular problem. Our nephrology colleagues are not going to get involved till later stages, and now they're talking about either some, funky glomerulonephritides, or they are talking about transplant and dialysis and all that kind of stuff. But very much like blood pressure that used to be a nephrology disease at one point, and lipid that used to be an endocrine disease at one point, and this is squarely in cardiology. I think UACR is squarely within our practice. Also, when I talk to some of my cardiology colleagues at my hometown in the practice, there's still a lot of misconceptions, like it's difficult to do, you need urine collection and all that kind of. I mean, none of that is true. When a person goes for their blood test, you basically just order it. It's relatively very cheap. It is a spot urine. They can just give the urine sample anytime that they are getting their blood test in a bottle, and then you can get it checked as well. So I think doing that becomes really, really important. Now, the other interesting thing that is being discussed here is to rule out diabetes. What do you think about that?
Yeah, I think this is actually quite helpful. You know, we often miss diabetes screening, and there are population level guidelines around how we initiate screening, and it may be infrequent in a general healthy population. But once patients actually develop comorbidities like cardiovascular or kidney disease, then there are recommendations for more upfront screening for diabetes. And here, especially with incident kidney disease here, it seems like a very opportune moment to screen for diabetes. Of course, diabetic nephropathy, while the causes of kidney disease are diverse, and this individual may have a number of causes, including overweight, obesity, hypertensive disease, but then also diabetic kidney disease, screening for diabetes actually is a key opportunity here, I think.
I mean, I'm always fascinated, and we have done this experiment many times over now. This is not one clinical trial, many times over, that patients come in with MI, with heart failure. In clinical trial, we draw their blood in the hospital setting. They have no diagnosis of diabetes, and then you assess their blood for hemoglobin A1C, and up to 30% of those people without a history of diabetes have hemoglobin A1C in the range for the diagnosis of diabetes. So this, you know, when we, you know, in some of the clinical trials, I just sort of have a rule to just multiply by 2. So when they say duration of diabetes and they say, you know, 5 years, well, that's when it was diagnosed. It was probably there for like 10 years and like nobody diagnosed diabetes. So I think that ruling out diabetes in patients that you're suspecting at high risk is really a good idea. So from a perspective of CKM, I think we are pretty certain that this person has the K problem, but we want to evaluate the M problem and the C problem. And again, the C problem in terms of the risk factors, this person, you know, blood pressure and lipids is certainly a concern.
This patient has a normal A1C and fasting glucose, CK levels are normal, thyroid function testing is normal, and the resting ECG is normal. The LDL cholesterol is 154, HDL cholesterol is 40, triglyceride is 130, NT-proBNP level is 200, serum creatinine level is 1.6, BUN is 24. Let's take a look at how our colleague ChatGPT responds. For this patient, treatment should focus on cardiovascular risk reduction and kidney protection. Start with atorvastatin to manage elevated LDL and reduce atherosclerotic cardiovascular disease. Lisinopril or another ACE inhibitor should be considered for renal protection and blood pressure management given the patient's GFR of 60 and serum creatinine of 1.6. Empagliflozin or another SGLT2 inhibitor could provide additional cardiorenal protection even without diabetes. Lifestyle interventions such as weight management, diet, exercise are essential adjuncts to medical therapy. And just to note, we have not altered this in any way. This is ChatGPT in a sort of real-time fashion. And I'm you know, to me, I'm a bit surprised. I mean, it's pretty good. But let's see if we can improve upon that. So I think the key take-homes from the ChatGPT response was we should focus on cardiorenal protection in this individual. Seems like initiation of atorvastatin or a statin therapy is important for CV protection, lisinopril or an ACE inhibitor for renal protection, and empagliflozin or another SGLT2 inhibitor for additional cardiorenal protection. So, Javed, I'm going to ask you, we have moved as a community towards pillar-based approaches in heart failure, especially heart failure with reduced ejection fraction. And now we seem to have a mounting evidence that perhaps that pillar approach should be adopted in chronic kidney disease. So this person now has established chronic kidney disease that's albuminuric. And so should you be treating this person in a sort of combination approach with all therapies all at once?
Yeah, so there are two schools of thoughts out there. So first, I think that ACE inhibitor and SGLT2 inhibitor is probably appropriate therapy for his CKD because the data that we have with finerenone right now is in diabetic kidney disease. and the data with flow with GLP-1 also. So I think the evidence for non-diabetes related chronic kidney disease needs to mount, and we are getting there, but we are not there right now. But let's just assume, for argument's sake, to answer your question, if this patient did have diabetes and we now have actually 4 drugs, what to do? So there are 2 schools of thoughts out there. Some of our nephrology colleagues, very erudite, their suggestion is, why give all drugs to everybody? Because if in 1 or 2 drugs, if the renal dysfunction starts improving and the risk of renal progression is very slow, why complicate therapy? So their rationale is to give 1 drug, check for albuminuria in 3 months, 6 months, see what happens. If the albuminuria is not down by 30–40%, is still elevated or going up or whatever, then add the second, wait another 3–6 months, see what happens, and then another bite. So don't take what the heart failure doctors are recommending, which is simultaneous initiation and concomitant therapy with all 4 drugs. And I think at some level, this idea is very reasonable. Check UACR, see what's happening with the renal dysfunction, and then add. I particularly don't like this idea. And the reason for that is that albuminuria is a very good marker for incident cardiovascular disease. We don't have as good a data of albuminuria being a marker of reduction in cardiovascular disease. In other words, if the UACR has gone down, that shows that the risk of kidney disease progression has gone down. But the risk of cardiovascular disease, remember, the #1 cause of death in patients with CKD in stage sort of the 3A, 4, it's cardiovascular disease. And I think that all of these clinical trials have shown improvement in cardiovascular outcomes in CKD patients as well. Incident heart failure, hospitalization, stuff like that, that I would personally prefer that we give all therapy to our CKD patients similar to what we do for heart failure patients. But this is my opinion, and I think the community is sort of engaged in a dialogue and will evolve. I don't know what you think about it.
No, I agree. I thought that was very eloquently put. And, the follow-up question is, a patient like this who we may be seeing in cardiovascular care or primary care, now what guidelines are we looking at? I mean, it seems like the hypertension guidelines are going to be applicable, the kidney disease guidelines are going to be applicable, maybe even some of the cardiovascular prevention guidelines are going to be applicable. And so how do you actually put that together as a practicing clinician?
So there are 2 good news here. So one is that, as I mentioned, sort of there's no discrepancy or controversy in these guidelines. So they're all sort of basically saying the same thing. So it's not that one is saying this and the other is saying this, and now you don't know what to do. So actually, if you can follow any of those guidelines, I think it'll do a patient a lot of good. The real question that you're asking is that what if you go to one guideline and they have not addressed one issue because it's just not relevant to that particular guideline, right? So that's a really important issue. Like the heart failure guidelines, they're not going to spend a lot of time talking about lipid management, for instance, right? So the good news is that we are at the AHA annual meeting. So the AHA came out with this presidential advisory for the CKM syndrome, and now there is a CKM sort of management algorithm guideline that is being worked on as well. So I think that your problem will be solved soon.
If the patient only wanted to initiate one medication at a time, which one would you prioritize?
Okay, let's see what we find out.
ChatGPT will solve all our problems here.
Given the patient's concern, prioritize starting atorvastatin to lower LDL and significantly reduce cardiovascular risk. This is especially important because the patient has dyslipidemia and elevated atherosclerotic cardiovascular risk. Lisinopril for blood pressure control and renal protection can be added next, particularly due to the patient's slightly reduced eGFR. Empagliflozin can follow, offering additional cardiorenal benefits. Starting with atorvastatin allow the patient to ease into the medication therapy with follow-up to monitor tolerance before gradually introducing other medications. But I have to say, I am really belly aching on this answer. I don't think I can live with that answer. I just don't know how to, I mean, like, how do you say manage lipid and don't manage blood pressure? I mean, it just, I don't know.
No,
what
I
do you
agree.
think?
I'm impressed that I was on ChatGPT side until now in terms of the responses. I thought they were pretty reasonable. I was thinking about
No.
using it in my own clinic, but this was a bit too confident.
I don't think, like, I mean, look, if there is an issue with, expensive drug and the cost is an issue or whatnot, and that's a consideration, that's a different story. But from a medical perspective, I don't think you can pick and choose first or the second, and especially if they're generics like lisinopril and atorvastatin. I mean, I would formally disagree with ChatGPT. Okay. So prioritize initiating, so that's their perspective. What would you have done differently? So I gave my answer. What would you have done differently?
No, I think convincing the patient seems appropriate. Between lisinopril and empagliflozin, all the clinical trials of SGLT2 inhibitors were really done on foundational RAS inhibitors. Those were mandatory in these trials with near 100% use. And so because lisinopril is targeting kidney disease progression and blood pressure lowering, seems to me that is a good priority. And of these axes, I think I would select lisinopril.
So at least, I mean, I would like to just take a stab at the last two questions here and see if you have a different answer. So how do you address these concerns with the patients? So at least in my experience, that patient which is just sort of simply unreasonable is incredibly rare. I mean, even most of the patients who may be a little bit lower on their educational spectrum, if you sit, I mean, our problem is that we're just too stretched running in too many directions. But if you take 5 minutes and talk to the patients, regardless of their educational background or whatever, most people are pretty reasonable and they understand what you're trying to do. Now, they may not still do it because of fear or other reasons. So, I mean, that's, shared decision making. I appreciate that. But I think people do understand if you take some time to explain them. And then the second thing, how do you initiate these medications simultaneously? And I just want to make sure that we sort of debunk this myth. The simultaneous does not mean Thursday afternoon at 1:30 p.m. start 4 drugs at the same time. What simultaneous means is not to do sequential, like I've talked about the UACR thing. So there's no reason, and again, you sort of have heard my bias, I don't find any particular reason that treat lipid and then wait for 2 months and then treat blood pressure. The idea here is 1 visit, 2 visit, over the phone, whatever it is, but in close proximity, without any preference, just go ahead and start the medications as soon as possible.
I agree, especially for drugs that, of course, don't have interactions with each other. I think that some people have expressed concerns around separating side effects. If you start 3 drugs all at once, and the patient does experience, let's say, a side effect, how do you attribute it to a single therapy? So in that case, I think spacing them out slightly, I think, is helpful, at least, and may add confidence to the patient. So this is the next query, which is the patient's transthoracic echocardiogram reveals an LVEF of 42%. The patient meets criteria for NYHA class 2 functional status. Would these findings change your treatment priorities? So let's see what ChatGPT says. Yes, the patient's reduced LVEF and NYHA class heart failure shift the treatment priority to heart failure management. Start with lisinopril or another ACE inhibitor, as it reduces mortality and morbidity in heart failure with reduced ejection fraction. Empagliflozin and SGLT2 inhibitors should also be prioritized, as it provides proven benefits for heart failure patients, including improved outcomes and reduced hospitalization. Atorvastatin remains important for cardiovascular risk reduction, but focus on starting heart failure therapies first, given the new diagnosis of heart failure. Careful monitoring and patient education are essential during initiation. So what I heard was reduced EF now shifts the priority, that we should prioritize heart failure first. Still, thoughts were to start with the ACE inhibitor and SGLT2 inhibitor, and atorvastatin was moved a little bit down the list. So curious here, this is a person now with sort of borderline or kind of mildly reduced ejection fraction. Would you manage them the same way? The guidelines are somewhat lukewarm or in between in terms of how we manage these patients.
So can I disagree with ChatGPT again? Yeah, so again, I honestly don't see any reason that just because you have a low EF, that heart failure is more of a priority than lipid. And I just don't see any reason why we should be shifting the priority. I think that they have multiple diseases, and all of those diseases need to be taken seriously and treated. But the other point that I will make, and this is just my opinion, I completely realize that EF of 40% or less, the quadruple therapy is a class 1 recommendation, but this person has EF of 42, so technically has heart failure with mildly reduced EF, and in that sense, use of ARNI is a 2B recommendation, MRA is a 2B recommendation, beta blocker is a 2B recommendation, only SGLT2 inhibitor is sort of a class 1 recommendation. Realizing all of those things, I honestly think if your EF is less than 50%, the secondary analyses of those trials are sort of good enough that, and the fact that there's a 7% plus minus range for EF on echo in terms of the accuracy, I would probably treat this person with quadruple therapy.
Yeah, I would agree. I think that especially because we have to remember the history here, this patient also has albuminic kidney disease, and so we are going to be using some form of an MRA in this person to ultimately delay disease progression of kidney disease, will be important in their heart failure management. Their blood pressure was elevated, might not be, a single therapy is uncommon in blood pressure management in the US, and so angiotensin receptor neprilysin inhibitors are very effective at blood pressure lowering, and so might serve, again, that adjunctive purpose. And so I think that I too agree. I think that this is seems like we should be managing this person as heart failure with reduced.
Also, I'm not entirely up to date on the diabetes prevention guidelines per se, but this is a kind of patient who doesn't have diabetes, but he's a total setup for diabetes, that at some frequency, once a year or something like that, just making sure new onset diabetes is ruled out is probably a good idea in this patient.
Yeah. So this is just some general educational considerations for initiating an SGLT2 inhibitor. I don't know if you have a script of that you could share, perhaps, Javed, of when you do prescribe an SGLT2 inhibitor, is there some things that you just definitely don't miss on and you definitely mention to the patient?
Yeah, so we're kind of running late. I mean, I'll just make a few points. So if you're giving it to a person, an SGLT2 inhibitor for diabetes, it's just easy because you have some diuresis, osmotic diuresis, natriuresis. Well, just make sure you drink plenty of water. But we don't have that luxury in a heart failure patient, right? So we have to just be a little bit careful in managing their diuretics, make sure that they're not intravascularly depleted, but not take too liberal oral intake of fluid as well, and that not increase fluid as well. The genital myocardic infection, on a relative scale, there's a 3-fold higher risk, but at an absolute level, the risk is less than 5%. So it's like 0.7 versus 2.1%. And that risk can be substantially mitigated by genital hygiene. So washing the area with water and keeping the area dry and clean makes a significant difference. The third thing is that the risk of ketoacidosis is actually very low, could be further lowered if you are, there are all sorts of surgical and procedural guidelines. I would say just make it very, very simple. If you are not going to eat and drink right, just stop your SGLT2 inhibitor. For whatever reason, I'm going through my appendectomy, double pneumonia, getting intubated, going for surgery, Crohn's disease is acting up and throwing up and not taking medication. For whatever reason, if you're not eating and drinking right, just stop the SGLT2 inhibitor. Once you're up and about and eating and drinking and you're back to your normal in a couple of days, then go ahead and start an SGLT2 inhibitor. That will lower your risk. But the bigger issue with ketoacidosis is not the risk of developing ketoacidosis, which is there, a small risk, but which is there. The bigger risk is that the diagnosis is delayed. And the reason the diagnosis is delayed is that, a person calls you that, I have belly pain, nausea, vomiting, I'm not feeling well. They have type 2 diabetes, and you tell the patient, do a finger stick, whoa, my sugar is 650, okay, fine, you have DKA, go to the emergency room. The very same patient with the very same disease will call you and their blood sugar will be 198 because they're peeing glucose. And we don't necessarily make the link till they get very sick, show up to the emergency room, and then somebody check ketone bodies. So just tell the patient of this possibility so that if they are not feeling well and you as their physician is not available, that they go to some urgent care or whatever, that they tell that I'm on an SGLT2 inhibitor, and for you to have a lower threshold of doing that as well. So these are sort of the top things that I would think of. Suppose the patient has a hemoglobin A1C of 9.2 and fasting glucose. Okay, so now we are in the diabetes range. What happens then? Yes, if the patient hemoglobin A1C is 9.2, fasting glucose indicates poorly controlled diabetes. In addition to heart failure, I would prioritize initiating metformin to lower glucose, glycemic control. Lisinopril, EMPA-atorvastatin will continue. SGLT2 inhibitor will help glucose control as well, although you're giving it for other reasons. And then regular monitor blood glucose, hemoglobin A1C, and renal function. So I finally completely agree with ChatGPT. This is great.
Yeah, I would sort of disagree.
Okay.
This is a person who is overweight and has an A1C now of 9.2%, has uncontrolled glycemia, is already on an SGLT2 inhibitor, which is being continued for CKD management. I think early integration of a GLP-1 receptor agonist, if covered and insured, makes sense in this patient, and seems like it would have evidence, certainly now in diabetic kidney disease. Presumably it's one cause of this patient's kidney abnormalities, and can be used alongside the SGLT2 inhibitors. I think it can skip the line in terms of, I don't necessarily see that there's a reason to start with metformin for diabetes management in 2024.
I agree with you also.
Super. So for time, perhaps we'll keep moving. Suppose this patient had a normal A1C and normal fasting glucose, but had a recent MI. So you're seeing the different iterations here. Let's see how ChatGPT actually handles this complexity. If the patient had a normal A1C and fasting glucose, but experienced a recent MI, I recommend initiating the following treatments: lisinopril for blood pressure management, atorvastatin for dyslipidemia, empagliflozin for heart failure management, beta blockers to improve outcomes post-MI, especially if symptomatic or has a reduced LV function, antiplatelet therapy, aspirin, or clopidogrel. All right, Javed, what is your sort of temperature there? Do you agree with ChatGPT here?
Yeah, so we did this study called EMPACT-MI. It did not hit the primary endpoint for all-cause mortality and heart failure hospitalization, but there was a pretty substantial 33% reduction in new onset heart failure events, heart failure hospitalization, worsening heart failure events per se. So the issue here is, first, although these patients were acute MI patients who were simultaneously now being started with an SGLT2 inhibitor and possibly RAS inhibitor and possibly MRA, and they got a cardiac cath, and they got an angioplasty, and they got dye exposure or whatever, we have published this paper, there were no renal concerns, so the safety was not an issue. So in other words, if somebody comes in with an MI, and they already have a SGLT2 inhibitor indication, like heart failure, like diabetes, like CKD, you should feel pretty comfortable, regardless of the MI, just starting those therapy because they have an indication. Now, for those patients that have none of these other indications and they just come in with MI for the first time, that paper is in review. We looked at that subgroup of people, and there was same benefit for heart failure risk reduction per se. So I think that it's a reasonable thing for you to consider in your patients when they come. So which healthcare professional will you include in this multidisciplinary team management for this patient that has all of these comorbidities? Primary care or cardiologist should coordinate the care, ensuring comprehensive care. Consult with a pharmacist is essential for multiple medication management and optimization. Diabetes management with dietitian, nurse educator for comprehensive management. And if the patient has emotional distress, then we can involve a mental health professional as well. Okay. and effective communication between all of these is really important. Okay, so that's pretty much self-explanatory, although nobody picked nephrologist here. Okay. I think that nephrology probably, especially if you have a little bit more advanced lowering of GFR or hyperkalemia, can be pretty helpful. Okay, we're running late and I really want to leave some time for our audience questions. So let's see. So these are just the key takeaway. We have been talking about all of these things, about the common comorbidity, increasing burden, and that we can treat these simultaneously because of common risk factors and common medications that affect these things, and the importance of multidisciplinary care. Why don't we move on? We have about 10 minutes for Q&A. Okay, role of SGLT2 inhibitor in non-diabetes CKD.
Yeah, so strong data. While some of the trials, the CKD outcomes trials, were restricted to patients with type 2 diabetes and concomitant chronic kidney disease like SCORED, like the Credence trials, the more recent trials like DAPA-CKD and EMPA-KIDNEY did enroll patients with both diabetes and non-diabetes, so a diverse range of pathologies of chronic kidney disease were well represented. So strong data for use even in non-diabetic kidney disease.
So there's a very nuanced question here. So what is the role of SGLT2 inhibitors in non-diabetic kidney disease without albuminuria? In other words, the GFR is low, but there's no demonstrable albuminuria. So again, it depends sort of, if your GFR is maybe 60, that's a different story. But as the GFR goes down, the albuminuria invariably kind of comes up. But I would say that in EMPA-KIDNEY, that went all the way down to really low levels of albuminuria, as opposed to other trials that had 200 or 300 as part of the inclusion criteria. You're pretty much seeing the benefits. So I think it's pretty reasonable to consider an SGLT2 inhibitor in those patients as well. How do we implement AI technologies as point of care? I don't think we are there just quite yet. So I think all of these apps that might help you write your notes or collect data and all that kind of stuff, that I think is progressing pretty well. AI to read images and read, echoes and pathology and all that kind of stuff, that is advancing pretty fast as well. But AI coming up with disease algorithm for management, that's I think is a step behind, but I don't know.
I agree, but hopefully some of the responses here gave you a taste of its potential, even in aiding in real-time clinical care. Javed, is a polypill upcoming? Are we going to see combination use of these therapies in a single pill?
I mean, it's a technical problem, so some of you may not know. If you combine two pills, that is, from a regulatory perspective, a novel new drug, so you have to do all the research all over again. So when we say polypill, what usually people mean is over-encapsulation. So you take individual pills and put them in one pill, in one capsule, and over-encapsulate. The problem with that is that there are only so many pills you can put in, because then they get pretty bulky and difficult to swallow. But I think that there are data in primary prevention. There is NIH just funded a trial in heart failure patients. It's an MRI trial for polypill, and there's another one in review process for ASCVD. So yes, pill burden relates to adherence, and the world is moving in that direction.
Perfect. So there's a question around the safety of initiation of some of these therapies, even with very low GFRs. And so is that something that we know that they're indicated for chronic kidney disease, but sometimes with very low GFR, we're a bit uncertain.
Yeah, so remember that the dip in a GFR, when you start, say, for instance, an SGLT2 inhibitor or an ACE inhibitor, it's not perfect science, so take it with a little bit of a pinch of salt, what I'm saying. But the degree of drop in eGFR is actually associated with better improvement in outcomes, because the degree of drop in eGFR is related to intraglomerular pressures and how high they were, that when you gave the drug, that is the amount of drop that you saw. The problem that you run into is that within reason, if somebody's creatinine was 1.6 and it goes to 2, like that's great, no problem. The problem is that we give ARNI that has diuretic properties, we give loop diuretics, we give SGLT2 inhibitor that have diuretic properties, and we give MRA that may have some degree of diuretic properties, although we give relatively small doses. So the question is, at what point is it intraglomerular hemodynamic changes versus intravascular volume depletion? And I think that there is no really algorithm here. We'll just have to use our clinical judgment, exam, talk to the patient. But before compromising medicines like MRA or SGLT2 inhibitor, I would cut down the dose of loop diuretic and give patients a little bit more volume to deal with it.
Yeah. There was a couple of questions around finerenone, which I'll field. The first is, can we use it in non-diabetic kidney disease? We saw that example. However, the clinical trials, the pivotal clinical trials were conducted in people with type 2 diabetes and concomitant CKD, so that's the indication. Parallel trials are now being conducted that are a bit smaller, but are focused on non-diabetic kidney disease, so we'll see. Right now, we use them primarily in people with diabetes and kidney disease. However, importantly, linked to the second question, what if the patient had HFpEF, which was the focus of the Fine Arts heart failure trial? And in Fine Arts, a large number of patients, in fact, the majority of patients did not have diabetes, so those patients were well represented. There's a question around dosing of finerenone. So finerenone right now is available in 2 doses, 10 milligrams and 20 milligrams. This is for the kidney indication. If the GFR is less than 60, you start and target 10 milligrams. If the GFR is above 60, you can up titrate to 20 milligrams. In heart failure, in Fine Arts heart failure, we studied higher doses, up to 40 milligrams, but that dose is not clinically available right now. So if you're using finerenone in clinical practice, you can follow the CKD guidance for now until the heart failure indication gets approved.
There's one question which is pretty straightforward. Can SGLT2 inhibitors and GLP-1 receptor be used together?
Yeah, so I think they have distinct mechanisms of action. They are largely complementary. There have been very nice intermediate trials, smaller trials that have shown that the combination leads to additive benefits in terms of albuminuria reduction, weight loss, improvements in surrogate measures like A1C. So I think that they can be safely combined and are indicated for many patients, especially those in stage 4 CKM.
There's an interesting question here for which at least I am completely not qualified to answer, but I will anyways. And the question is the role of plant-based protein versus low-carb keto diet. What kind of diet is best for each stage? So again, I don't follow this diet literature per se, but out of interest, I've read some, and my best read right now is that it really doesn't matter. At the end of the day, it's all about net calorie intake versus how much you are expending. So one, a lot of the fasting that you do and you just cut down on the calories, whether it is you're cutting down overall calories or doing long fast and all that kind of stuff, at some point in the beginning you lose weight, but then your basal metabolic rate goes down and you don't lose even with that same calorie restriction. That's one thing. And if you don't do exercise simultaneously along with weight loss, you get a skeletal muscle loss as well, and you sort of are not feeling as rigorous. So continuing to do aerobic and some resistant exercises while you're trying to manage your calories. If you go on internet, there are all sorts of formulas out there for calculating basal metabolic rate, calculating per activity, and you can get a pretty good idea of how many calories you burn. And then if you can just cut down, say, 200 calorie deficit a day, slowly, but keep exercising, you'll lose weight. So how you do it, again, I'm really not qualified to give this answer, but my best read is that what diet you follow is really a preference of what taste you can live with, as opposed to one is magically good versus one is not magically good. It's all about energy balance, calorie in versus calorie out.
So in the last couple of minutes, we have a question around selection of ACE inhibitors versus ARBs. And this is a complex issue, and I think the data has largely evolved and undulated over time. For the management of chronic kidney disease, especially diabetic kidney disease, the largest trials that were conducted were actually with ARBs about 2 decades ago that showed clinical benefits. However, then if you take populations like heart failure, we have perhaps a bit stronger evidence with ACE inhibitors. Now guidelines have made it simple and call these renin-angiotensin system inhibitors, and it is up to the clinician. Javed, I don't know if your perspective's different.
No, completely agree with what you're saying. Now, we are right at time, but let me just wrap up the program. So for our colleagues who want to go and make a little bit of the night, that will be great. So again, thank you very much for attending this session. Visit us at peerview.com. Download the slides and practice aids. The practice aids are really nice, so you might want to really download. You can maybe give it to some of your office staff as well. Thank you so much. Great.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical educational grant from Boehringer Ingelheim Pharmaceuticals Incorporated and Eli Lilly and Company. To access all materials for this activity, visit peerview.com/RWH860.